As promised from last time, this time we're going to take a quick look at something called knowledge translation, a field of scientific research and communication that has arisen within the last 10 years. The two goals of this podcast are to give you a sense of why knowledge translation is important, and also give you a stepping off point for sketching out your plan. This podcast will not make you an expert on this topic, but it will give you a starting point. In a highly simplified word, knowledge translation, or KT, is the bridge between what most of us associate with research and the application of research findings to end users that will benefit from it. There are significant alliances between KT, education, QA/QI work, and also something called patient-engaged research. In a previous podcast, I put it to you that a large proportion of research funding may be wasted. One reason is a project that dies before completion. But there are more possible explanations. What if the study is sound, but nobody knows about it? What if the end users don't engage with the findings because it didn't address their actual problem? This is the zone where KT lives and does its work. Don't dismiss the importance of avoiding reasons 2 and 3. Granting agencies are on tighter and tighter budgets, and they want to see their money bear fruit. The philosophical and conceptual framework on which KT is based is beyond the scope of this podcast, and it takes a while to get a grip on the terminology. However, for our purposes today, the aim is to answer 3 questions. Who's going to be impacted by your findings? How will they learn about your findings? And how will your findings create change? The answers to these questions will form the backbone of your KT plan. As clinical researchers, there is a basket full of potential stakeholders and knowledge users depending on your specific project. You'll have to expand your thinking beyond other surgeons and researchers to capture the full list for your particular work. For example, let's say you've done an audit on the effect of DOACs on time to surgery for hip fracture patients. You've determined that patients on DOACs wait about 65 hours for surgery, and the literature suggests that waiting more than 48 hours can adversely affect morbidity and mortality in hip fracture patients. Potential knowledge users and stakeholders are surgeons, patients and their families, family physicians, internists, and hospital policymakers. Getting your message to each group will have to have its own approach, since policymakers don't tend to read orthopedic journals, and internists and general practitioners may not be aware of the unintended consequences of these medications, which are usually prescribed for very legitimate reasons. Patients and families need to understand why they are waiting and waiting for treatment. Next, you'll need to identify your strategies for getting your knowledge to your stakeholders. Dissemination refers to the process that you're most familiar with, peer-reviewed conferences and publications. Diffusion refers to a less formal, more social movement of knowledge. An example could be a hallway discussion with a colleague, or an unplanned discussion during a case rounds. Transfer is in principle a one-way transfer on an institutional level, but this is the fuzziest of all. Exchange implies a two-way movement of ideas. An example of this would be getting researchers, health policy makers, and patients together to problem solve based on the new knowledge and group contexts. Implementation will refer to a practical action. This diagram is the core of KT. It's like the CanMed's flower of KT. Most of us spend all our time at the fat end of the triangle, while some of us get into the synthesis and maybe even tool creation. But have a look at all the stuff going on around the outside. Welcome to the action cycle. Let's look at this with an example. You're a surgeon at Hospital H, whose caseload is primarily outpatient surgery. You've been looking at ways to improve your practice and reduce your footprint on hospital resources. Literature you've been reviewing from another institution suggests the following. Preoperative anxiety is a huge predictor of early post-op pain. Poor pain control increases the risk of admission after day surgery. Admission after surgery costs the system a fair bit of money. And there's a promising medication, X, that given preoperatively can substantially reduce anxiety and pain scores. So you're pretty interested in giving this a go at your hospital. KT is already in progress because you know about these important findings. So how will you get this to work at your hospital? First, we need to establish who the stakeholders and users will be in this grand plan. If we're talking systems change in day surgery, patients, nurses, surgeons, anesthesia, pharmacy, MOAs, and policymakers all have a stake in this and need to be accounted for in the change strategy. This is your audience. Next, what are the large steps required to get the overall goal of implementing and monitoring these new findings in your arena? One scheme would be to ensure everyone knows why and what, that eligible patients have access to medication X at the correct time, and that all eligible patients are actually taking it, and that the medication X is having the desired and expected effects in this new context. So then the question is how you're going to reach the various stakeholders with the message geared to their situations. Your goals need to have strategies. For patients, they need to know what the point of this is in language that they can access and understand. Concerns about side effects, potential costs, and denial about pre-op anxiety being a problem at all are some of the issues that will need to be dealt with. Nurses, other surgeons, and pharmacy techs will need information relevant to the rationale and implementation. Finally, visual aids in clinical areas where this medication will be implemented or discussed are helpful. Skipping down the column, you'll need to figure out ways to get the administration and monitoring of administration of this medication integrated into the care pathway. Extra work or tasks outside the normal flow of work have poor uptake. Finally, you need to determine if the findings of the original research are actually being observed in your local environment to help provide the impetus for long-term adoption if medication X is actually working like you think it will. You can easily see here why this is a field all by itself, because this is already really complicated for what initially sounds like something pretty simple. Finally, you have to actually have the resources to make this happen. So let's go back to the action cycle. We've defined our problem in brief, and we have an intervention we'd like to adopt in our local environment. We need to adapt the protocol for our institution. How will patients get the medication, and who will ensure it's available at the right time? As we go, barriers may be impeding our success. Pharmacy inventory might be too low under current purchasing policies, or if patients are to bring the medication with them, they might forget, be resistant, or unwilling or unable to afford it. Staff workload and non-routine nature of medication administration may lead to poor adherence to taking it at the right time. If you've identified barriers or potential barriers, you'll need to address them. Monitoring is important, as is evaluation. Finally, you want a successful change to maintain itself without the same level of effort. So you want to think about sustainability and long-term policy change. Obviously, the previous example is not going to be representative of every researcher's KT involvement. Our example came at it from the standpoint of implementing completed research by someone else, but the thought process for translating your own work is not that different. The same GACER table can be used to sketch out what you anticipate will be the knowledge translation strategies that will help your work achieve its application. The time to consider this is early in your study design, not at the end. Start with the traditional forms of publication and presentation, but don't stop there. If nothing suggests itself, consider whether you're asking the right research question. If you're not sure your target audience will be interested, ask them what they'd want to know and how they'd like to learn it. Finally, the University of Calgary has dedicated KT experts who can consult and help you make better sense of this. This presentation has barely scratched the surface of the world of KT. I'd at least recommend the CIHR Integrated KT booklet, and the link is on this slide. This is a good introductory primer, and it helps take you through some examples and ideas. For a more theoretical philosophical overview, the CMAJ series covers a great deal more, and is the source of our key KT diagram. Knowledge translation is not going away, and in the present financial crunch for research funding, a good KT plan may go a long way to helping you succeed. KT is a new field whose goal is to ensure uptake of useful research findings where they're needed the most. Your knowledge translation goals should be an upfront plan, not an emergency exit plan at the end of the project. The good news is that there are people to help you with this. In the next podcast, we'll look at interacting with another important research consultant, a statistician.